Dr. Bardava, and Selena for allowing me to do the activity and sort of be the guy to help train this whole thing and not split it up into many segments. I think that's important. We have a real opportunity here with the mortality we're seeing with overdoses from this disease to make a difference. The whole point of the activity is to identify this disease earlier in its life cycle and to go ahead and treat this illness while you can still save a life. So here we are with part 2 of the May curriculum. Medication access and training expansion. That's the technical term for this. Came out of the Consolidated Appropriations Act this January 2023. And what that does is remove the federal requirement for the X waiver. If you're in here, I imagine you know what the X waiver is. That was the stipulation that you had to have extra training to prescribe and use buprenorphine, which was a DATA 2000 medication for opioid use disorder. So now all practitioners who have a DEA license will be required to be educated on addiction and how to use buprenorphine, life-saving medicine. SAMHSA and DEA got together and said, here is the curriculum of the 8 hours of training that we think would be adequate to move forward with lifting this waiver. And hence the reason you all are here today, and everyone with a DEA license will be taking something like this. So they have the competency to identify and treat addictive illness. If you missed part 1, let's do a summary of part 1. Addiction is synonymous with substance use disorder and is a treatable medical illness defined by low dopamine in the survival circuitry of the brain, also called the nucleus accumbens. The same way Parkinson's disease is low dopamine in the substantia nigra, you have low dopamine in the nucleus accumbens for your definition of the disease of addiction. New information for most of us, I believe. Addiction has a heritable component and is subject to genetic loading. That conveys a vulnerability to the individual as the disease may emerge at any point in life. Yes, that includes birth. Yes, that includes 45, 65. Genetic vulnerability. The disease may be primary or secondary. The evaluation of this disease is done using the American Society of Addiction Medicine dimensional criteria. Dimensions 1 through 6, you give them a risk rating in all 6 dimensions. And then you refer them to the appropriate level of treatment. And the final point made from part 1 was that buprenorphine reduces both morbidity and mortality for those with opioid use disorder, and SAMHSA's quick guide, along with the PCSS, Providers Clinical Support System, as practical tools to implement buprenorphine use into your practice, if you feel appropriate. Now, here we are on part 2. Part 2 will be, the goals are, describe co-occurring mental disorders in the setting of substance use disorders and concurrent medical illnesses. Explain emerging threats in opioids and the importance of educating a patient and their family on overdose prevention. Discuss best practices regarding managing patients' pain with co-occurring substance use disorders. Recognize the importance of communication between medical specialties in caring for patients with substance use disorders and using the PDMP. Implement the utilization of presented specific addiction medicine documentation required to treat and manage individuals with substance use disorders. So if you're going to go out on a limb and treat someone with addictive illness, you have to have the right paperwork and documentation to do it. So we'll look at that too. A little bit dated, but we'll take 2017, but the data kind of came from 2008 and 2014. We're looking at just under 40% prevalence of co-occurrence. So if somebody has substance use disorder, just under 40% will probably have co-occurring mental illness. If somebody has mental illness, you look at it reverse. How many folks with pure mental illness also have co-occurring substance? That's a little bit, that's half. Basically that's going to be half the other number, as in less than 20%. If you extrapolate those numbers to what more current data says is the prevalence, see, we initially thought that the disease of addiction was just under 10% of the total population. So we were wrong. The number's higher, and it's 16.5. I think it's closer to 20, but let's say it's 16.5 because that's what the data shows. So in that case, 38% would mean 17.5 million people have co-occurring mental health problems with their substance use disorder. That's a pretty large number. So what are we going to do about this co-occurring? First, we should probably understand what we mean by co-occurring. 2 things occurring together, 3 things occurring together. I could have pre-existing mental health problems and then have addiction problems. I could have pre-existing addiction problems and then have mental health problems. I could have pre-existing substance issues and then have a medical problem like a liver problem. So all of this is co-occurring. And the thing to remember is that genetic predisposition is likely the vulnerability that allows addictive disease to emerge, either as a primary diagnosis or a secondary diagnosis after significant medical or mental health issue or other significant life stressor or circumstance. So I'm going along in life with my diagnosed lupus, and I don't take care of my lupus, and I got joint pain daily, and it's riding on me. Meanwhile, one member of my family, let's say my dad has addiction, my mother does not. I'm carrying a vulnerability. 10 years into my partially treated or not treated lupus, I started to have sleep problems with it. And so the pain of the lupus combined with some other stressors in life, let's say at that time I went through a divorce as well. So I got some emotional, life-changing events and stress going on. Yes, I can get a 3rd or 4th thing that emerges on top of all of that. I can now emerge with a substance use disorder midway through my lupus and through my depression or through my anxiety, and congratulations, I've got number 4, a new diagnosis, substance use disorder on top of everything else. Is that fair? Is that right? It happens. So we just need to be aware that this is an emergence of a new medical condition that needs to be treated on par with everything else. We don't just take care of the lupus, we don't just take care of the depression, we go ahead and take care of this new illness as well. And back to the illness. What is the illness? For this reason, stress, genetic vulnerability, I have emerged with low dopamine in the nucleus accumbens, and here we are. Pathologically, basically pursuing relief. Relief of I need to feel better. Something's wrong here. So the answer to the high prevalence of co-occurring disorders is treat all of them concurrently. If indicated, recognize that mental health component may be substance-induced for the first 30 days after the last use of a substance. Treat intrusive symptoms that interfere with receiving needed treatment or interfere with daily functioning. And the principle of simultaneous treatment of multiple diagnoses applies to co-occurring medical problems as well as mental health. Okay. So let's break that down a little bit. Until proven otherwise, if I recently used excessive amounts of alcohol, cocaine, or opioids, and I'm presenting with a mental health problem, there's a good chance that it's either made worse by, and it could even be caused by, the substance. So we have to take that into account when you're looking at patients. Now, if they're presenting with significant insomnia, you still treat the insomnia. You just might not be able to call it due to depression. You might have to basically refer to the label of substance-induced mood disorder, substance-induced insomnia, until proven otherwise. So that's why abstinence is recommended. You can't really hope that Lexapro is going to treat severe depression if I'm drinking a 5th of Jack Daniels a day. How much Lexapro? What dose do you want to make it to try to treat You build up a small berm, a very small dune about 2 feet high on the ocean, and the waves coming in, and it's about 6 feet. And you say, man, I built up this 1 foot dune here, this little berm. It's going to hold it, right? You can't ask the impossible. These medicines were not designed to be able to deal with the flood of neurotransmitters and problems and whatever else is created by more powerful substances than Lexapro. So let's look at what is going on with the individual person. So the reason we do that, per the slide here, is it's difficult, if not impossible, to treat medical and mental health conditions if substance use disorder is active. Active heavy drinking or use of illicit substances can prevent medications from working or may introduce increased risk when taking them. They just don't go well together. It's also difficult to know whether the presenting condition may regress if drugs or alcohol are removed from the picture. Boy, I've seen that 1,000 times. I'm 45, 60 days into recovery, and lo and behold, I don't have antisocial personality disorder, or I don't have depression. I'm doing so much better. These even personality traits that are maladaptive seem to melt down. And a lot of the mental health problems seem to get better too. Happens more often than you may think. And co-occurring medical examples that seem to melt down in early recovery, in a good way melt down, as in regress, remiss, or may not even be there, is hypertension. How many folks have seen folks with alcoholism present with hypertensive urgency or crises? Hypothyroidism, GERD, insomnia. Could throw in GI bleed for sure. Malnutrition, liver dysfunction, anemia, just general bone marrow suppression, where it's like, my goodness, it's pancytopenia. But they're drinking pretty heavy. Let's see how that pancytopenia looks after 90 days of abstinence. Oh, it's gone. Let's say CHF, cardiomyopathy, coagulopathy, and then we move into psychiatric disorders, personality disorders, mood disorders, anxiety disorders, psychotic disorders, and cognitive impairment can all improve when the folks get into recovery or abstinence from use of drugs and alcohol. Why aren't my meds working, Doc? I've reduced my drinking from 750, a fifth of vodka, down to 375 milliliters of vodka. I'm still depressed, anxious, and forgetful. I think you have the wrong medicine or the wrong dose on me. I stopped all my illicits, and I'm only taking kratom tea. You know it's natural. And I'm still anxious, and I have insomnia. And the medication you prescribe is obviously wrong. Kratom's got to be safe, right? Because it's natural. It's a plant, right? Can't be bad. They all come from plants, and some of them are synthetic. But yeah, it's an opioid. It can act as a stimulant at lower doses, and it can act as a sedative at high doses, and it's a mu receptor agonist. And the withdrawal from kratom looks like fentanyl or morphine withdrawal. And you gotta treat it as such. So therapy and psychotropic medications have a difficult time working when the individual is intoxicated or in a state of withdrawal. Therefore, first things first, stop drugs and alcohol under medical guidance and supervision, because why? I can die from withdrawal from alcohol, benzos, and barbiturates, right? So I can't just tell somebody, you don't need any help, just stop drinking a fifth of vodka a day. I have to medically guide them through that or help them with it, I would think. So that's where the dimensional assessment comes in. That's ASAM, Dimension 1. What is the risk level in Dimension 1? And where do they need to complete this detoxification? I just got a patient from a great doctor who started an ambulatory detox protocol. And this doctor said to the patient, I am not going to look at your AST and ALT elevated anymore and your albumin low. You are going to detox because you are killing yourself, and it's not happening on my watch. So here's a Librium protocol. And I'm going to call you every day, and you're going to come into the office every other day. We're going to do vital signs, and you're going to see Miraboli or whatever addiction doctor is near you. Well, that patient did come in, and they're doing well. So my point is, don't underestimate your intervention and your relentlessness to sort of say, we're going to do something here. You're scaring me. Your health is scaring me. You're on a precipice here. You might not appreciate it, but you can either have a seizure or have a bad outcome, something worse. The DSM-5 criteria for substance or medication-induced mood or mental health disorders. Okay. Here's the criteria. We need to have a disorder that represents clinically significant symptomatic presentation of a known mental disorder. Okay, so something is maladaptive, recurrent, clinically impeding. We need to have the disorder developed within a month of using the substance. And we must have some evidence that that substance or medication is capable of producing the said mental health condition. So that's part of the kind of positive criteria that you need to have. Something that meets diagnostic criteria, but yet they've used within 30 days. And then there's a caveat. It can't really have been there years before they used. So if I've been hospitalized for mental health problems before I pick up a drink or a drug, it's probably now they have two things. You can't necessarily say it's all due to, it could be made worse by using it, but it might not be causative of the mental health symptoms that you're seeing. So that's the caveat in part C there. And of course, the person cannot be undergoing a medical emergency, such as delirium, and it has to obviously impair several social, occupational, and other important areas of function. So these categories, alcohol, cocaine, opioid, sedative, hypnotic, these are all of the sort of DSM classified specific substance categories. But remember, as I go through all this in the specific substances, remember one thing. It's one illness in the sense that addiction is addiction is addiction. Does it matter that I switch seats on the Titanic? I still have it. Whether I like opioids, whether I like alcohol, whether I like cocaine, I have addiction. Low dopamine in the nucleus accumbens. So don't focus too much on the substance category, but yet to help the person, you need to know what category it is, because you need to know what medicine to use, and health-wise, what's going to happen to them. What's their likelihood of a seizure or of having a respiratory depression? I want to make a note that other unknown substances, in the DSM, that does include anabolic steroids. And there's a new one on the scene, xylazine. There's hallucinogens, include dissociatives, which are a little bit different. You don't have a lot of lifelong magic mushroom takers. I don't know if you ever met anybody who, for 40 years, has used hallucinogens like mushrooms. But you do see people who, for 40 years, use PCP, dextromethorphan, ketamine, the dissociatives, and that has to do with the propensity or ability to release dopamine in the reward center of the brain, and thereby treat my primary problem. But the hallucinogens, it just seems like doesn't last as long, doesn't seem to be a lot of people going around with that. And probably because the dopamine release in the nucleus accumbens is less. But I've seen a share of, there was that group of a time where we were seeing a lot of the triple C's, cortisone, cough, and cold over the counter, where they're coming into the emergency room after dextromethorphan intoxications, and it mimics PCP and dissociation. This is the chart from the DSM, page 482 of DSM-5. Look at this chart, filled with information. My goodness. If I use a substance what could it potentially cause? The substance could cause all that stuff at the top. Look at that. Psychotic disorders, bipolar, depression, anxiety, OCD, sleep disorders, sexual dysfunction, delirium, neurocognitive disorders. And then the others are just DSM classification. But look at that. So now the I is for intoxication phase. The W is for the withdrawal phase. And the P is persisting symptoms. I want to draw attention to a couple of things, like let's start at the top with alcohol that can cause just about everything. I can be psychotic, alcohol-induced psychosis during the intoxication or the withdrawal phase. I can have alcohol-induced bipolar disorder in the intoxication or the withdrawal phase. I can have you get the point, right? How about the little p there, persisting? I can have persisting neurocognitive changes at the hands of long-term alcohol use. What does that even mean? It means that my short-term memory, my long-term memory, my processing speed, my visual memory, my auditory memory, my verbal memory, all of the domains that we test neurocognitively, neuropsychologically, can sustain what? Lasting and maybe permanent damage, possibly. So this is why when you get a safety-sensitive worker on your practice and you're thinking, boy, should I sign this note saying they can go right back to the nuclear power plant control panel? It's just a simple signature. They've only been drinking 20 years, and it says right here, just sign here to return to work. If it's a safety-sensitive job, you better think twice. And they probably need a neurocognitive test. What if they have no depth perception? What if their manual dexterity is gone? What if they forgot what you told them 5 seconds ago? Do you think that matters for some jobs? I mean, we're talking about, airline pilots. Let's say any of us want to work in a hospital, right? There it is. I mean, the responsibility here is big, right? Because we could have existing change. It's the P, right? What else do we have? Inhalants. So yes, there are some people, I have treated a dentist who liked nitrous oxide. And it caused some lasting neurocognitive damage, and they were not able to return to practice because they had central nervous system damage. Now, the good news in some of this is that heals. Not always, but a lot of times. You can have, the dog used to be what? Central nervous system damage, you're done. And now what? Plasticity, epigenetics, all kinds of science saying, look, well, maybe not. Maybe, we're doing some things with physical therapy, like when you have a stroke and you can't move your arm, what do? You go to physical therapy, and the physical therapist moves your arm for you while you think about moving your arm. So you actually don't need to move your arm, do you? And then half the time, 6 months later, they're moving their arm. Explain that to me. So, fake it till you make it means something. You might have to go through the motions and have your patients enter treatment and go through the motions of being well. And then lo and behold, they're tricked into being well 6 months later. How about that? So, persisting deficits. Look at that, inhalants. So, I guess that might not be any surprise, but you know what? There's another case I'm thinking of. This one was an LPN, and she was sick because of alprazolam, sedative hypnotic. We're talking 8 to 10 milligrams daily for about 10 years. Persisting neurocognitive change. I can't get it clear. Every 6 months we test her on the neurocog test. You know what? Persisting deficits that weren't there before the use. Who knew that benzodiazepines can cause cognitive impairment that lasts? I mean, we're told in med school and in training, they're so safe. I mean, compared to barbiturates, I guess they are. But if I'm on 8 to 10 milligrams of alprazolam for 10 years, did you know you can have cognitive processing difficulties? You can have visual and auditory memory problems. You can have processing speed issues. You can have a lot of things that aren't helpful in the long run. So I want to draw your attention to that neurocognitive disorders line in the P for persisting. So it's not like once you're done with withdraw your fine. I'll tell you the one that's up and coming, and there's not a lot of, I don't think there's a P on there, cannabis. Number 3, cannabis, because that's basically in the water now, right next to the Marlboros. And the strength of cannabis now, it's not like, the 60s with 20% or whatever, it's high strength stuff. And there's some research coming out saying, not so fast. Oh, there it is. JAMA Psychiatry, published May 24th, 2023, as in like 3 or 4 weeks ago, indicated cannabis use disorder, increased risk for both psychotic and non-psychotic, unipolar depression, and bipolar disorder. And it's a pretty large study. 6.6 million individuals, average of 18 years. And so, psychotic, and once in a while you see, potentially younger or older. For me, it's been some of the younger people where it's like, doctor, they come with their parents. And maybe in that experimental phase of life or whatever, and they try cannabis. Now, this cannabis is supercharged, whatever, and they have a psychotic break. And you're trying to advise them what to do because they're having symptoms of psychosis. Is this early schizophrenia? Is this depression? What's going on? They have real mental health changes as a result of this cannabis use. And it maybe happens over a couple of years of them using. And you're trying to advise, because they're asking, it's been 3 months, is it going to go away? I mean, we're certainly outside of that DSM criteria for substance abuse. So now are we looking at a more permanent or more longer lasting situation? We don't know. We don't know. I send a lot of them to the Menninger clinic and have a full, thorough neurocognitive workup over it and see, is this emerging? Because it's right around the age where you can start to see, psychotic disorders such as schizophrenia emerge anyway. So are we looking at a genetic vulnerability that was maybe exploited or brought out by high potency cannabis? Because that's what the next study at Lancet seems to indicate, is that this large genome-wide association study says that there's a shared genetic risk for cannabis use in psychotic illness, pointing to co-occurring genetic vulnerabilities. So, is that bringing something out, or is it an independent finding just because I use cannabis and it's going to react? I don't think we know yet. But there is research saying there is some genetic vulnerability, not only for substance use disorder, but for mental health problems. Who gets treatment for co-occurring substance and mental health disorders? Not enough. The majority do not. The majority do not. 47.5, I guess, do. But they're partitioned, right? So 34.5% receive mental health only, 9% receive both mental health and substance use, and 3.9% receive substance use treatment only. This is data from NIH and NIDA. It's a little bit dated in 2017, but the idea holds in the sense that not enough people are being identified and treated for dual diagnosis problems. Here are some of the barriers to getting treatment. The slide on the left starts with mental health treatment, barriers to mental health treatment. Why don't I go get mental health treatment? Number one reason, could not afford the cost. Number two, I didn't know where to go. Number three, could handle the problem without treatment. At least I thought I could. Fear of being committed is on the list. Might cause neighbors or negative opinion of people around me. Next is I didn't think treatment would help and didn't have time, and I was concerned about confidentiality. That's for reasons not to get mental health from this particular survey at NIH and NIDA. Reasons for not getting substance use care. I'm not ready to stop using. Now that's a loaded one, not ready to stop using. You knew where I was going to go with that. Not ready to stop using. Really? Are they really having so much fun? The people you see, it's like they're having a good time. They're not ready for the madness to end. It's just a lifelong party. They're doing so well in all aspects of their life, and they're thoroughly, thoroughly happy. Oh, give me a break. Before it was relieving anything, it was relieving something 10 years ago, 20 years ago. Life is miserable for them now. They are ready to stop. But just like weight loss with cancer, guess what? This disease, when I have it, my perception is skewed. My perception is I need to protect what I think I need at all costs. And so right now what they think they need is a powder, a liquid, a process, something to make them feel better. So that's the perception that they're protected, is the perception that they need that to be okay. They don't really have faith that something else is going to work. And they tried tons of other things that don't work. But this does quite efficiently, or did. And something in my memory center is saying, I remember when it worked, why isn't it working now? Let's do it again. Maybe if I add a little something to it, it'll work differently or better. So let's go to reason number 2. Had no health insurance, could not afford costs, might cause neighbors to have a negative opinion, might have a negative effect on jobs, did not know where to go for treatment, had insurance but did not cover treatment, no program had the treatment type that I needed or wanted. Well, there is a little theme there, if you feel it or you see it, bit of the stigma. The stigma's still there, whether it's mental health or substance use disorder, it's like I have leprosy. And it's like, wait a minute, this is medical. This is not leprosy. If I have type 1 diabetes, am I under the table? Do you see your type 1 diabetics hiding their face from you? They just come in and say, I had cake. I ate cake. I like cake, and my sugar's high. Let's go on to the next thing, doc, right? So we need to bring this into the light and sort of say, like, yeah, you're a good person with a bad disease. Let's see what we can do to get your sugar down, so to speak, or in this case, your dopamine up. Because that's what it's all about, increasing dopamine levels in the right area of the brain. How do you get more patients the treatment they need for co-occurring? Well, you help them see the power of the illness and its unintentional effects on those around them. If you were here, for the last talk, I mean, this is the thing. I never meant it to cause harm to the people that I love, and when it does, that just might be enough energy to get me help. If we're going to look at consequences just on myself, it's going to be lacking. Because my mind has already self-justified some amount of pain and hurt and missed opportunities for myself. I did not sign up, though, for it to hurt the people I love. And that's where you want to press. You want to press on that and help them see that the disease is strong enough that happened. See, it's not about shame and guilt. It's the fact you help them see that the disease is that strong. So you got to move them from shame and guilt into shock and awe. Shock and awe about what? That it's that strong. Look at what happened. You didn't mean it, but it's proof positive that it's that strong. It's not you, it's it. Look at what this cancer did. You're down to a BMI of 18. Use evidence-based communication strategies to include shared decision-making and motivational interviewing and motivational enhancement therapy. It's key to have support members and significant others present, if possible, with the individual when discussing the need for treatment. Who here thinks that's a good idea, to have a significant other or a support person present? Anybody? Who thinks they can get traction all by themselves and just convincing them how wonderful treatment and recovery is? Who has met a true voluntary patient for treatment for substance use disorder? Voluntary is a misnomer. I never met anybody who thought it was a good idea to go to treatment all by themselves. Have you? Been doing it a long time. I don't know what that is. But I do know what somebody sitting next to somebody is. I do know when they have the caring of a physician, a provider, a caring of a family, a sober support person, the caring of a neighbor, a caring of a friend. When they are sitting next to the person, you have got a shot. Why do you have a shot? Right? You're sitting in the room, you got the patient with their disease, right? And there's only one you. You need to level the odds, level the playing field. You bring in another person who cares about them, right? They're sitting next to you, and the person's there with their disease. Now the disease is on its heels, so to speak, and you've got a little leverage. You've got to use it. So then you try to look for the right level of care based on the ASAM dimensional assessment and the DSM diagnosis. So what is their risk rating? That's in the first lecture. Risk rating on 6 dimensions. Is it high, medium, or low risk in each of the dimensions? That will guide your placement as to where they should go. Could I take care of them in my own office? Could I send them to the residential treatment facility? Could I send them to intensive outpatient? Where should I put them? Well, that's guided by their risk rating in the ASAM dimensions, along with their DSM diagnosis. So do they have mild, moderate, or severe addictive disease? Like other medical diseases, let's go back to lupus, mild, moderate, severe. Let's go to diabetes, mild, moderate, severe. Some need insulin, some don't. Let's go hypertension. Used to be stage 1, stage 2. We can have mild, moderate, severe, right? So this is the same thing. If there's an outpatient treatment plan, you'll need a support person, to help them with their medication because they're coming to you with a problem controlling pills and medication. So if you can get them to have a helper initially, they gain muscles though. Over time, they get stronger and they're able to do it. But initially, they're their most fragile they're going to be. So just realize that when you're helping and seeing these people, it's a fragile time, and they're a month, 2 months, 3 months into it, they're going to have different skill sets and be able to manage their own medications. And the contingency plan is kind of that agreement where we'll give this a try to do this outpatient if it's appropriate, and if it doesn't work, I agree to go to a higher level of care, maybe residential or in partial hospitalization or intensive outpatient treatment. And these are some of the sort of phrases, terminology we need to bring into the light here of what's really going on. Help the individual move from the shame and guilt to shock and awe, as we mentioned previously. I'm sick, not bad. I'm a good person with a bad disease. I'm a person with substance use disorder. I am not an addict or an alcoholic. I am a person with major depressive disorder. I'm not depressed. Help them understand the concept of shame versus guilt. So if I keep feeding myself monikers and framework that I am this, I am that, is sort of defining, the person where that's not the person. I may have become the person I didn't want to become, but I was sick. And when I'm sick, I'm not myself. But when I'm well, I can really be who I'm meant to be. You can help the individual and the family really understand that using chemicals is only a symptom of their underlying need to increase their neurotransmitter levels or to address another core issue. Yeah, addiction can sort of present